on COVID-19 and the vaccine hesitancy in Aboriginal communities. I'm Nikki Trudgett. I'm a proud Wiradjuri woman, and I am also the General Manager of Aboriginal Health and Wellbeing. To kick off, I would like to start with acknowledgement. So I'd like to start the meeting by acknowledging the Aboriginal and Torres Strait Islander people on the land on which we live on, and I would like to acknowledge the Wiradjuri Nation as I am located in Bathurst. I'd also like to acknowledge that we work on the traditional lands of many Aboriginal clans, nations, and pay respects to elders past, present, and future who are the knowledge holders, teachers, and pioneers, and the youth who are the hope for a bright future and will be our future leaders. I acknowledge and pay respects to Aboriginal people who have gone before us and recognise their continuing contribution to Aboriginal people, culture, and community. We are committed to working in the spirit of partnership and collaboration within our regions of Aboriginal communities and peoples to improve their health and well-being. I warmly welcome any Aboriginal or Torres Strait Islander people who are with us today and pay my respects to you as well. Okay. Just to start, a little bit of housekeeping. So if we could get your full name in the chat box, just so we can keep a record of your attendance, that would be fantastic. We ask that you mute if you are not speaking, and if you could possibly wait to the Q&A session to ask your question. When you do ask your question, if you could turn your webcam camera on so our panelists and our speakers can know who they're talking to, that would be fantastic. To ask a question, we can just put up your hand in the conversation, and then I'll be able to get to you and ask you for you to speak your question. Although if you have questions over the time of while our speakers or panelists are speaking, just write it in the chat box and we'll be able to come back to it later. Also, feel free to react to comments or react to our speakers as they're talking. This will give us a lot of information going forward, so it'd be great. Today we have two guest speakers. We have Paddy Cashman. Paddy has worked in Victoria, Tasmania, New South Wales, and in emergency, infectious disease and remote health. He is currently the immunisation coordinator at Hunter New England LHD. Paddy's interests include communicable diseases, because I can talk today, Aboriginal health, health worker education, and adverse effects following immunisation surveillance. We also have Dr. Amy-Lea Perrin. Dr. Amy-Lea Perrin, is a proud Wiradjuri woman from Dubbo. She is also the GP and CMO of the Dubbo Aboriginal Medical Service. On our panel today, we have Therese Gale, who is our Practice and Support Improvement Officer for the Western New South Wales PHN, and Jamie Keed, who is the Practice Manager of the Dubbo Regional Aboriginal Health Service. All right. Now, sorry, this is my one. So this is just a snapshot of where we're up to with COVID at the moment. Since the 6th of October, we've only had 45 new cases. 785 of the total cases that we've had in our LHD have identified as Aboriginal or Torres Strait Islander. 3,730 in total across New South Wales have been infectious Aboriginal or Torres Strait Islander, and 21% of those were in the Western LHD area. So far, unfortunately, we've had 9 deaths occur in the Aboriginal and Torres Strait Islander community. Yeah, that one's one that we might like to reflect on, is quite how it affects our communities as well. I'm sure we've seen in the media a lot of people being affected by these in the very remote communities. If patients aren't able to access their digital vaccine portal, there may be a problem with transmission from medical services, e.g. communications notifying the vaccine of the Australian Immunisation Register. For any help with this, please contact Michelle Droulis from our team. She is an Immunisation Cancer and Screening Coordinator for the Western PHN, and she'll be able to help you with that. All right, handing over to Paddy now, who's going to present to us on the COVID vaccine.
Oh, that's wonderful. Thanks, Amy. So yeah, I'm Paddy Cashman. I'm a non-Aboriginal guy, but I'm currently sitting on Kamilaroi land in Tamworth and working at a RFDS vaccination clinic in a sports centre today, and just ducked off to talk to you guys today. And thank you very much for the invitation. So this is the Uluru Statement that I'm sure everyone's familiar with, and I think it's very powerful. So in 1967 we were counted, 2017 was Seek to be Heard. That's 4 years ago now. We still haven't seen any progress. This is the pretty version, but you can just bring up the A4. It's just a one A4 statement, and it's just beautifully written. So I really encourage you to have a look at that, especially for the non-Aboriginal audience here today. Next slide, thanks. So why do we vaccinate? Why do we give vaccines? Now, we've been using vaccines for a long time. We've been using vaccines for decades, and it's the cornerstone of primary health and how we keep people healthy. Now, this poor little infant, a little neonate, has neonatal tetanus, and that's made that baby as stiff as a board. Now, we know if you're lucky enough to be handling babies in your job, babies are beautiful and soft and sit in your arm, and they're just gorgeous. But this poor little baby's as stiff as a board because it has neonatal tetanus. Now, we can prevent this by giving a vaccine during pregnancy. And most women around the world, we don't need to in Australia because we've got good quality obstetric services, but most women around the world are deliberately given a tetanus vaccine in pregnancy so the baby doesn't end up like this. Now, in the 1980s, we had 500,000 neonates die of neonatal tetanus every year. And now that's down to 20,000 around the world, which is really good, but that's still 20,000 too many. And this is just with a simple vaccine. So vaccines are not new and crazy. Vaccines are how we do health and how we keep people strong and healthy. They save lives so people can have long, happy lives. Yep, and that's what it's all about. So I was looking for an example of talking with Aboriginal people today. So where else in the world, because Aboriginal people are unique and special, where else in the world have similar people faced a terrible COVID crisis? And the obvious answer is the First Nations people in North America. So last year in North America, there was no vaccine. Vaccines weren't around. Yep, COVID came through and swept through, and the graph on the right shows that the Indigenous people in North America suffered much more than the other people, including the Black people and the Pacific Islander people. So just a terrible crisis, and that's what we expect to happen with COVID if it gets into Aboriginal, or it's already here, but when it comes more in Aboriginal communities. And on the left-hand side is a sad picture. The Sioux tribe, it's a funeral at one of the Sioux tribes funerals for a person that died of COVID. And you can see there the numbers. So the Indigenous infection rate in the United States was 3.5 times the infection rate of other people, hospitalizations 4 times. So this disease finds people living in tough conditions, sometimes overcrowded, and there's a terrible health outcome. But it's a really good news story in North America. Next slide, thanks. Because the First Nations people there have taken control and they're leading the vaccination. Yep, there's no vaccine. Oh, I don't know if there's vaccination hesitancy, but they're really leading the vaccination charge in North America. So this is numbers from July. And at that stage, there'd been more First Nations people immunised than the rest of the community. And you can see on the right-hand side, this is a CEO of one of the urban organisations. You can see on her mask, be a good relative, and that's their sort of catch cry, be a good relative. And that really, I think, rings true with Indigenous communities. And I thought that's a picture on the left of the Navajo people, who are the most populous nation in North America. But I thought this quote was really interesting. It says, the language you hear throughout Indian country is be a good relative. Do this for the grandmas. Do this for the ceremony. Do this for the language, because our people are precious. We already lost a lot. We can't afford to lose any more. And that's the message with the vaccines. In New South Wales, we call this culture, Aboriginal culture. So we want to preserve Aboriginal culture, and we do that by vaccinating. So vaccinating is in harmony with Aboriginal culture, to preserve Aboriginal culture so you guys can keep it strong. I'm a health worker. I'm a white guy. I'm not here to talk about culture. That's for Aboriginal people to do themselves. But I'm here to say, well, let's stay alive, keep Aboriginal people strong so you can practice and do your own culture and pass it on. And I think that's a really powerful message. But there's lots of other messages out there that get confused. So the lady in the red dress is saying, the vaccines have arrived so fast. How do we know they're safe? And the guy with a beard, or is it a mask? I think it's a beard, is saying that the things that have been sped up is the administration and the funding, not the science. So the science, the technical side of making these vaccines has all been done properly. Now, usually, very, very sadly, the sort of diseases that we vaccinate, we see a lot more in poor people and especially in poor countries. Yep. And if a vaccine works really well, you have it once, you never go buy another one. Yeah. So it's a terrible investment for pharmaceutical companies. They don't like putting money into vaccines because it's a terrible way to make money, because poor people get sick, poor people die, and you give one once, they never need it again. Much easier to make lots and lots of blood pressure products for rich people, and you can sell them every day and you make a fortune and it costs nothing. But with this pandemic, there's been lots of investment in vaccines. And on the right-hand side is a graphic. So on the top is the developments going along one after the other after the other. So they make the vaccine, then they build the factory, then they do this, then they do that. But what's happened with this is that all those steps have been done at the same time in the lower part of that diagram in parallel. And that's why it's been quick. It's not quick because it's been rushed. It's not quick because it's dodgy. It's quick because we needed it quick, but the science is fantastic. Next slide, thanks. But there's all this misinformation. So this is an article I found in Scientific American, which is a popular science magazine. And it's a story about, because it's one thing to be vaccinated, it's another thing to be able to prove that you're vaccinated. And in poorer countries where there's poor record keeping, that's a big problem. So they came up with this sort of invention. You put some dye underneath the skin, and in that's embedded a story about the vaccine that you've had. And then you can scan that with your phone. So if you haven't got paper or records or stuff, it's a really good way to do it. But it's not in production. It's not put in the vaccines. And look at the date of this. This was the 18th of December, 2019. 18th of December, 2019. 13 days before the virus was known about. Yep. So I think this has got mixed up with the new vaccine information. So this is not in the vaccines that we're using at your AMS. This is just a news story about something that's not used anywhere. So this idea of marking people is not the case. Next slide, thanks. But just a quick look at how the virus works and how your immune system works. So there's the virus at the top, and then it gets into your cell, and then it opens up and the RNA comes out of the virus and it replicates and replicates, and then it pops out of the cell. And that's when that funny shaped thing there, this thing here, that funny shaped thing, that's your antigen presenting cell that meets the virus, recognizes it, and presents it to the rest of the immune system. And then you make antibodies, which are the little blue Y-shaped things, and T cells, and they will remember then. And then if you ever bump into that disease again, in this case COVID, your body will remember. So this is how your body fights diseases. You've been doing it for 60,000 years. It's how people survive from generation to generation. So this is what we do with medicine. Good medicine harnesses what the body does, and that's what we do with the COVID. Next slide, thanks. So if you break your bone, yeah, the orthopedic doctor, she doesn't go in there and put your bone together. She sets it straight, either externally or internally with pins and plates, and then your bone heals itself. And it's the same with making antibodies. Any infection comes, and then if we recover, we make antibodies and we're there to fight it next time. But the problem is if you recover, that's a bit of a trap. So the idea with the vaccine is you make the antibodies first, and then you bump into the disease. So this is about first make the antibodies, then bumping into the disease. So we saw with First Nations people in North America, they're really good at vaccination because they've seen this terrible disease. But in Australia, the highest rates of Aboriginal immunisation are in Melbourne because they've seen the terrible disease and the mob there are getting vaccinated, followed by Western New South Wales. Whereas the people in WA haven't seen any disease, and up top of the Cape, in Queensland, they haven't seen any disease and their rates are really, really low. So this is not waiting till we see disaster all around us. This is having the vaccine before you see the problem. Next slide, thanks. Because what's in the vaccine is not much. So on the left-hand side is the active ingredients in the Pfizer and Moderna vaccine. So it's just the active ingredient, which is the mRNA that I'll talk about in a minute, and then 4 lipids, 4 little fat things that keep, it's quite delicate, which is why we've got to store it properly. But they then can slip into the cell. So that's the job of those lipids. And 4, salt, sugar, and water. So because there's not much in it, there's not a lot of preservative. We probably buy food from the supermarkets that have a lot more preservative in it than these vaccines. And that's why we've got to handle them so carefully, because they're so delicate. Next slide, thanks. So the messenger RNA, what's this messenger RNA all about? So in our cells, we have our DNA, which is the double-stranded thing at the top, and that has the genetic material from your ancestors, and that's why you're so special. That's why everyone on the planet is so special, because your genetic material is yours. But then and obviously it starts with 2 cells way back at the beginning. Then to make more and more cells, that message has got to get out from the nucleus of the cell to the cytoplasm of the cell to make proteins. All our body's made from proteins. Our muscles, our kidneys, everything's made from proteins. But how does it know what to make? Well, it sends a message from inside the nucleus to outside, and that's the messenger RNA. So that takes a bit of a copy of the DNA and said, I'm going to make a kidney cell protein. And out it goes from the nucleus and into the ribosome, and it runs through it like a ticker tape and makes that protein. And it's just like a message stick. So the website where I pitched this slide said that this is a Wiradjuri message stick. And it's just like, you know something, you put the message on a message stick, you give it to someone else, and then at the other end, the person knows what's going on. And that's exactly what the message, it's a messenger RNA, and it's just like a little message stick inside your cell. It doesn't go inside the nucleus at all. This is how our bodies work. So this is what we do with the vaccine, is we copy nature. Next slide, thanks. And so there's our little squiggly messenger RNA in our little fatty globule at the top. The fats get it into the cell, and then it makes the spike protein, a copy of the spike protein, but a safe copy, so that we make then safe copies of that. And there's that funny shaped cell again, the antigen presenting cell grabs those copies of the spike protein, presents them to the immune system, to the B cells and T cells. You make antibodies and you build up cellular immunity, and then Bob's your uncle. Then you're right, then you're immune. Next slide, thanks. So this is what happens when you inject the vaccine. The vaccine goes in, and there's our little friend, a little fatty globule with the squiggly message stick, messenger RNA inside. That goes down to the ribosome, and you can see off to the left and to the right, the copies of the spike protein come out of the new proteins being made by the ribosome, and they're presented to the B cell on the left and the T cells on the right, and you make immunity. So all we're doing with these vaccines is we're putting a new message stick in there and saying, hey, this is how you make a copy of a spike protein. And we do that before we bump into COVID, so that when we bump into COVID, or our family or our community or our mob bump into COVID, we're prepared. It's like getting ready for an event. No good you prepare for the event after it's happened. No good training for the Olympics after it's over. You've got to prepare beforehand. So have the vaccine before you see the disaster from COVID. Don't wait till it's at your doorstep. There's been terrible stories of people being wheeled into ICU and they go, oh, doc, I can see this is dangerous now. Can I have that vaccine? The doc just looks at the person and says, it's too late. Not now. It's too late. Don't leave it too late. Next slide, thanks. So we really concerned about vaccine safety. So we follow people up. So I started this program, Vax Tracker, about 10 years ago, and I'm doing a PhD in vaccine safety. Now, we've surveyed nearly 4 million people in Australia about the vaccines, asking them, how did you go? How are you? So we know these things are safe. And 55,000 Aboriginal surveys. So we've caught up, because Aboriginal people ask me, they say, that thing might be safe in America, but is it safe here? Is it safe for our mob? Well, we follow people up. So next slide, thanks, Erica. And this is data just from Aboriginal people. So 27,000 responses from first dose, 18,000 from second dose. And they've told us that, after the first dose in blue on that table, we feel a bit fatigued and we headache, and more so, over half with the second dose. So after the second dose, don't plan too much for the next day or two. You might be knocked around a bit, but that's your body building immunity. Then you'll be protected. On the top right-hand side, blue first dose, green second dose. One person needs to seek medical care after the first dose for Aboriginal people, and 2 for the second dose. So that's still very, very safe. And we see in that little bar graph on the right-hand side, about 20% of Aboriginal people take the day off work the following day. So look at the exciting number down the bottom there. The 100% of this data is from Aboriginal and Torres Strait Islander people in Australia. So we know what's going on with Aboriginal people. We're asking Aboriginal people to help us with the AusVac safety surveys, and they have, and that's really, really reassuring. As you can see, not unusually, it's mainly women filling this out more than the blokes. So any blokes out there, please remind blokes to fill out the survey for us. So how do we know this is going to work in Aboriginal people? Is it safe? Yes, yes, yes. And we follow people up. Next slide. Thanks, Erica. And the TGA is completely transparent. So the TGA look at all the reports of anything that's happened. So on the table on the right, that big number on the right-hand side of that table, 30 million doses given in Australia. So this is not an experimental vaccine. No one's a guinea pig. No one's being experimented on. Billions of doses have been given around the world. And the TGA have received 69,000 reports. Now, this is completely transparent. There's nothing hidden. Any reports that go to the TGA, it's up on their website. This is just from their website, updated on the 10th of October. Now, the thing that TGA are concerned about at the moment is pericarditis, especially for young men after the Pfizer vaccine and the Moderna vaccine. And here's the rates where they've been using these longer from the UK. The highest number there is 28 per million of pericarditis and myocarditis after the Pfizer vaccine. Now, unlike the clotting problem that we had before with the AstraZeneca, but we're not using that one at the moment in Australia, we're using the mRNA vaccines. This is a short-term, self-limiting, maybe you need some anti-inflammatory medicine, sit in hospital for a few days, check your ECG. This is not going to kill anyone. So this is something that can be managed, that you don't need to be frightened about. And it's open and transparent. There's nothing hidden. So if you're hearing messages that the government's trying to do something against you, it's not the case. The government's completely open and transparent about this. So this is sort of a good news story. So some politicians have tried to make misinformation with the reporting of adverse events, but that's not the case. Next slide, thanks. But in the UK, what we're seeing now is that most people who end up in ICU and dying are unvaccinated. So in the first 6 months of this year, of the 51,000 people that died of COVID in the UK, only 250 had 2 doses, and most of those very elderly people. So this is now a pandemic of the unvaccinated. Next slide, thanks. And in America, you're 20 times more likely to go to hospital with COVID if you're unvaccinated. Next slide. And as well as killing you, it also leaves these terrible long COVID, and it affects all different organs of your body, and it can be quite debilitated. Long COVID up to 12 weeks and post-COVID syndrome for 12 weeks or longer. So this disease really knocks you around. You want to stop that. You want to have the vaccine. Next slide, thanks. But how do you know what you know? How do you know the information? So there's this thing called heuristics, and we use heuristics to process information. We use heuristics to process lots and lots of information because you can't know everything. So these are little mental shortcuts we do. So maybe we're using a dodgy mental shortcut to make a decision that's potentially a life and death decision. So don't be led astray with the information that you're reading. So how can we analyze how we think? So the values, we bring our values, which is, of course, culture. And sometimes we give more weighting to a risk if it's highly publicized. So if you're reading lots of terrible risks on social media, you might think those risks are bigger than they really are. So you need to be reading carefully. And sometimes people anticipate something negative if we make a decision. So therefore we avoid taking the course. Oh, well, what if something happens to me after the vaccine? I don't want to do that to myself. I'm not going to take the vaccine. Or some people prefer an outcome of doing nothing rather than doing something. So that's the second last one. The third last one there we call omission bias. And the second last dot point, you avoid taking the risks when the outcome is uncertain. So if you're uncertain about the vaccine, you avoid it and then you don't take it. So what I'm saying is analyze, think about how you're getting your information, and don't be frightened because the vaccines are incredibly safe. Not 100%, but very, very close. The disease is incredibly dangerous. So if you're weighing up the risks and benefits, the vaccine comes out on top all the time. Now, if you're looking at information and not making that decision, then I'm saying, well, have a look at the information. Where are you getting it from? How are you making those decisions? Next slide, thanks. Now, this is a paper from South Africa where they're talking about vaccine hesitancy, and they're saying as well as those things, like how we arrive at information, there's also some people have been treated badly by the government for many, many years. Does that ring a bell for any Aboriginal people out there? So, and then sometimes, so you feel like you're excluded, so you're not going to believe the government, so you have a mistrust of the government, and that can lead marginalised people to distrust vaccination and to resist vaccination as a form of agency. So what the agency is there is it's saying that you're trying to be strong by resisting what the government's telling you to do. But in this case, the government is actually telling you the right thing to do. It's actually on your side. There's no trick here. There's no hidden agenda. Yep, it's just a simple vaccine like we give babies. You take it, you stay alive, and your mob's safe. It's as simple as that. So that, and obviously we want you bring culture to how we make the decision. But is culture should be keeping us strong. So is the vaccine an anti-culture thing? I don't think so. So the next slide's a bit upsetting, but I think we'll have a look at it anyway. So when, like, I'm a non-Aboriginal person, so when my ancestors came here 250 years ago, just 12 months, the year after they came, there was a terrible smallpox epidemic. Now, most of the people who were on the ships were immune to smallpox, but the local Aboriginal Gadigal people were not. And 70% were killed by smallpox just the year after the ships came. Yeah. And this is a terrible story from a judge. And he says that he had this, he calls him a native companion. And he says, those who witness his expression and agony will never forget. He looked anxiously around him at the different coves we visited. Not a vestige in the sand was to be found of a human foot. Not a living person anywhere to meet with him. It seemed as if, flying from the contagion, that they'd left the dead to bury the dead. He lifted up his hands to his eyes in silent agony for some time, and at last he exclaimed, all dead, and then he hung his head in mournful silence. So this is not the first virus that's come to Australia from the outside that Aboriginal people have had to deal with. This has happened before, so let's learn the history. In those days, they had no vaccines. At your AMS, they've got a fridge full of vaccines that can prevent this terrible sort of outcome. And these people were obviously strong cultural people, so culture's not going to protect you from the virus, but the vaccine will keep your body strong so you can practice your culture. The vaccine is pro-culture. So if you're worried about the vaccine because it's against your culture, I think it's the other way around. The vaccine's actually going to keep you strong so you can practice your culture. Next slide, thanks. Now in America, there's some radio hosts who are spreading anti-vaccination messages. This is a picture of one of them, and he actually wrote a comical song to the Beatles' Taxman. He called it Vaxman. And there's him. So his name's Phil Valentine. There's others that have spread the anti-vax message. And 5 of them are quite prominent, and all 5 chose not to get vaccinated, and all 5 are dead from COVID. Yeah, all 5 are dead. Now, 2 of them are reported to have rung their relatives when they're in hospital and saying, hey, this COVID's no joke, go get the vax. Yep. So I don't think Aboriginal people who are being strong in their culture should be getting their messages from white fellas in America. Yep, that's not the place to go down your AMS, get good information from your health worker, from your doctor, from your nurse, and talk to them about the vaccine. If you're making a decision not to have the vaccine, then I challenge you to think about how you arrived at that and challenge, because you don't want to end up like these guys. Yep. Next slide, thanks. And I think we can, if we vaccinate, we can stay strong, we can keep our mobs strong and practice culture and have a much brighter future. And if we don't vaccinate, even if it's not very many, it's still going to be enough for that virus to get into the community, because we know no child under 12 has been vaccinated yet. So take the vaccine, keep yourself strong, keep your mob strong. If you're uncertain, go talk to people who know what they're talking about, which is down at your AMS or other health service. And please be in touch if you've got any questions. Thank you.
Thank you for that, Patty, for the insightful information that we can then take back to all of our communities and hopefully keep all our mobs safe. Next, we have Amy, who's going to talk to us about the local COVID perspective. Amy, over to you.
Thank you, and thank you, Patty. That was very informative, and it really did express what we're sort of seeing on the ground as well. As I was introduced before, I'm a Wiradjuri woman from Dubbo. I've come home to work in the role of GP at my local AMS. And while it's been an interesting journey over the last 18 months, but especially over the last 7 months since our vaccines have arrived in the clinics. And I acknowledge, look, everybody's experience with this COVID situation is going to be different, but I've been asked to come and speak to you guys today about the things that we've seen on the ground here in Dubbo and challenges that we face and how we've sort of worked together to overcome those situations. So some of these things may be helpful to you guys in your practice, but they also may not, depending on your local experience. So what I found personally, before the vaccines were actually made available, the general feeling amongst the community was it was really positive. We were all really looking forward to the vaccines becoming available so that we could protect ourselves, so that we didn't see COVID in our communities and the deaths that we were seeing overseas. At that time, a lot of the media that we were seeing on our TVs and on the news were of these huge death rates, huge outbreaks in countries that we all recognise, like Italy, France, England. Once it sort of came to our shores, so I did notice a big switch in the narrative that we were seeing on the news. We weren't seeing these huge outbreaks on the news anymore. They tended to be affecting those countries that weren't necessarily going to hit the headlines, like over in India and Brazil. So all of that scary media started to fade away as people started talking more about vaccines. So prior to the vaccines actually arriving at our clinic, we made sure that we were all prepared for when it arrived so that we could start the rollout immediately. A lot of the staff had, started their vaccine training, but we made sure that we were all complete before the day the vaccines arrived so that we were ready to move forward. And we also had a lot of meetings together to brainstorm how these clinics were going to run so that we could anticipate any problems that might come up and, adapt quickly to anything that did change. So a lot of the things that we took into consideration in these meetings were, with the vaccine vials, how many patients should we bring through each clinic so that we didn't have any wastage? How could we safely accommodate those patients within our clinic so that we were following all of the health orders and not having, too many people in a confined space? We also looked at things like, where the patients were going to wait after they had their vaccination, who was going to supervise that, the data entry side of things, who was going to do that and upload things to air, but also the other logistics. So, what PPE was necessary in a non-outbreak scenario versus what we might need down the track if we were to see cases locally. So all of these things that we'd planned for so that we could keep our clinic flexible and adapt as things changed. Our first clinic was wonderful. It was a great day. Everyone was so positive. It was busy as busy could be, and we were exhausted at the end of it, but it worked really, really well. But sadly, in between clinic number 1 and clinic number 2, that was when we had the media release that said the ATAGI advice had changed and no longer was AstraZeneca a free-for-all. We were only allowed to vaccinate those over 50 because of the fear of TTS. I personally found that had a devastating impact. As a doctor, I understood why the advice changed, but I definitely did see a change in the vaccination clinics after that. We were all really hopeful that we were going to get absolutely flogged every time we had a vaccine clinic, that it was all going to be as busy as Clinic 1, and we were really going to get these numbers pushed through. Once the media started focusing less on the amount of deaths and disease overseas and started focusing on, patients that had died after vaccination, whether it was from a blood clot or a car crash, the whole narrative changed, and we were hearing a lot of conspiracy theories. This is when we started talking about, it's experimental. They're trying to kill all of us black mob off so that, we can see if it's safe for the white fellas. And our numbers really decreased. So our second clinic that we had, it was a bust. We had probably half the amount of patients show up that we had booked in. A lot of patients cancelled and others just didn't show up at all because they were scared. So unfortunately, over the ensuing weeks, there was a lot of media about clotting again. The advice had changed again from you can't vaccinate anyone who's under 60. Again, it really eroded that confidence in the AstraZeneca vaccination. So in turn, we had to decrease the amount of vaccination clinics that we were having because they were just dead. A few of my colleagues and I, thought in an effort to increase our patients' confidence in the AstraZeneca vaccine, instead of waiting for Pfizer to get our healthcare worker vaccinations, I'm only 38. A few of the guys are younger than 60 as well. We had our vaccinations with AstraZeneca. I wanted to show my patients that if I was going to be vaccinating them with something that I wanted them to have, I wanted to show them that I had confidence in that vaccination and that, I'm fine. I haven't grown a third head. I'm not magnetic. It's okay for you guys as well. And I even shared with my patients as well that, in that first few weeks of the clinics, I vaccinated my own mum. I vaccinated my grandparents. I gave it to my hubby. If it wasn't for my hubby, I would starve to death. So, it's a great vaccine. And I found for some of those patients, it really did sort of help to calm their nerves that, if the doctor's getting it and she's recommending it and giving it to her family, it must be okay. But there definitely was a lot of misinformation and disinformation that really did put a halter on that, the initial efforts in the vaccinations. At DRAHS, to try and, encourage the patients to come forward, instead of just saying, look, we've got vaccines, come and book in, we made an effort to actually approach our patients personally. So we got a list of all of our eligible patients, those with underlying health conditions that would benefit for vaccine, and we had a dedicated team of health workers and nurses that actually called the patients to say, we've got the vaccines, have you heard of them? Would you like to book? Is there anything you're worried about? And we got the opportunity for anyone who was hesitant or frightened, that they could book an appointment with either myself or one of the practice nurses to have a talk through what they were worried about, to see if they truly didn't want to have it or if we could convince them that it was safe for them. We did get an increase in numbers from this, but of course, there were some patients that did take a few phone calls, a lot more gentle coaxing, a lot more reassurance to get them across the line. And there were others that just flat out refused. They weren't having our poison. So all good. I still talk to them about it. I just don't engage in conspiracy theories. We did find that, actually something, just before I move on, something I found really helpful with the AstraZeneca as well was once I got a few of the prominent elders in the community vaccinated, I did find them really, really helpful too, because a lot of these guys, they love a good yarn. So they were going home and they were talking to, old mate next door, their brother, their cousin, telling them, look, I didn't die, just go and have a chat to the doc, see what she says. And we did get a lot of patients through word of mouth as well. So I think getting in the ear of those prominent people in the communities can be a really, really big help, and they can be really good allies when it comes to just that personal experience on the ground with them saying, look, it's fine, it's not as scary as it seems. Once Pfizer did arrive at the practice, we certainly did see an increase in the interest in vaccinations again, because Pfizer did do a great advertising campaign as, this brilliant vaccination that, was going to be the be all and end all. So we definitely did become more busy again. But of course, there was eligibility criteria with Pfizer as well. So to try and limit the amount of people we had to sort of say no to, we did put the eligibility criteria on our Facebook page, so that the patients could actually see whether it was their turn to get vaccinated, which did help a bit as well. With teenagers, when they became available, one thing we did do to try and also put it out there and get further advertising was we spoke to Clontarf and Girls Academy at the high schools to let them know that we were vaccinating teens, it was safe, and so that they could put information out there through their channels as well. And that was really quite helpful. During all of this time, like Pat, I saw a lot of different patients that brought through a lot of different conspiracy theories I hadn't even heard of. Talking about, microchips being turned into magnets, experiments, even down to things like, ivermectin, you should eat that, you should eat hydrochloroquine, let's drink terps. And I sort of thought, well, if these are going to be, if I'm going to actually be faced with this stuff in my rooms, I probably should read up on this stuff. So I actually spent a bit of time, besides doing normal doctor study, actually going down the rabbit hole on social media, which was quite an interesting experience, so that I could see where the patients were getting this information from, and I could actually reassure them to say, look, I've seen this, I've read about it, it's woo, it's not good for you. And I'm still doing that now, actually, talking about, different producers on TikTok that are probably better for the patients to be looking at, to try and change their algorithm so that they're not just getting the misinformation every time they open up their phone. Unfortunately, though, I think the only thing that really changed the vaccination rates in a big way was the fact when we got our COVID outbreak here in Dubbo. Prior to the outbreak, even with the work that we were doing, our single vax rates in the Indigenous community was only at 17%, and our double vax rate was at 8%. So when COVID hit Dubbo, it really did hit in a big way, and it got into a lot of our more vulnerable transient communities, which really increased the spread. And it also got through the high schools. So that first couple of weeks during the outbreak was very tricky. Staffing on the ground, a lot of health services was thin because, of course, all of us had kids at school that were affected and furloughed. Once the threat did become real, I think that really increased the urgency for a lot of patients as well. They saw that this wasn't just a disease for white people in Sydney. This actually is real. Rona's going to get us. So with that increased urgency and the increased vaccinations and assistance from places like, from the government giving us more vaccines, RFD, ADF coming to our region to help, we did notice a huge increase in the numbers of vaccinations very, very quickly. Of course, with that, we also had to change the way that we ran our clinic here in Dubbo. So we had a big number of people with COVID in the area really, really quickly. We didn't know who these patients were. General practices at the time weren't given information when our patients were crook. So we had to put things in place to make sure that we kept ourselves safe, as well as making sure that we were doing the best we could to keep our patients safe from transmission at the clinic when they were getting their vaccines. So again, we came together and brainstormed. We changed the way our clinics were run. We moved them outdoors, changed our PP up. We were no longer just in the surgical mask. We were full gowns, goggles, N95s. Got extra staff. Nacho and H and MRC were great to send us a vaccination nurse, and our RFD sent us a few doctors and nurses as well, which was awesome, so that we really could increase the amount of vaccines that we were able to give on any given day. We also looked at things like, checking in, making sure the patients were socially distancing, etc. And now, since we faced that here in Dubbo, even though we've had a lot of tragedy and a lot of sick patients, our vaccination rate as of yesterday out here for first dose was over 95%, and our double vax rate was over 80%. So we've done some really hard work over the last few months, which has been absolutely brilliant. And before I finish, I'm probably getting close to that 10 minutes now because I do love a good chat. I'd like to share a patient story from a patient that I spoke to last week. She gave me permission to share her story. She's a new convert to the wonders of vaccines, which I'm so happy about. Initially, when we talked vaccines with this lady, she was very hesitant. She didn't want to have it done. She thought it was rubbish. It wasn't 100% effective, so why bother? And she was very, very far down the rabbit hole of, people being made magnetic and things as well. So it was a bit tricky with her to start with, to try and convince her it was a great thing. She did eventually decide to have the vaccine because it was mandated at her job. So she did what she had to do, but she wasn't happy about it. About 3 or 4 weeks ago, unfortunately, a few of her family members became unwell, and she was quarantined in a very small home with shared facilities with 3 positive family members in, like I said, very close living quarters. Fortunately for this lady, she spent 2 weeks in quarantine with 3 sick relatives and came out the other side with no positive tests. She's now a vaccine convert. She called me up to tell me how wonderful the COVID vaccine is, how no one can convince her otherwise. It saved her life, and she's screaming it from the rooftops now, telling everybody else that she's connected with to get vaccinated. So I think even though it's hard work to get, some people who are very hesitant to get vaccinated, there is hope. We can get through to them just by being patient, being gentle, and being persistent. That's me.
Thank you, Amy. That's such an incredible story, and it's so great that now you have community members also advocating for it as well. And the really creative approach that you've taken to getting people vaccinated is amazing. I just wanted to remind all the attendees that if we could get your full name in the chat box so that we can record who has attended today's session. But next up, we have the opportunity to ask our panelists and our speakers a few questions. So today we have Therese Gale from the Western Primary Health Network, who is our Practice Support Improvement Officer, and Jamie Keed, our Practice Manager, who will be joining, for Dubbo Regional Aboriginal Medical Service, will be joining our speakers today for a questions session. So if you'd like to type your questions into the box or raise your hand, I'll be able to direct your questions to them. Or Patty and Amy just covered it so well that everyone's in awe. Okay, we have a question from Virginia. Virginia, would you be able to unmute yourself so that our panelists will be able to hear you?
Sure, can you hear me? Yeah.
Sure can.
Yeah, I'm just wondering, especially with Amy and Patty, I'm just wondering, do you get a lot of questions in regards to young women in regards to pregnancy and stuff like that? Because I think I'm seeing a lot of young women that are declining the vaccine and have even chose, I think that's a big influence on leaving their healthcare jobs. Have you seen much of that?
I'm happy to take that one, Patty.
I guess with childbearing women, yeah.
Yeah, I've definitely seen a lot of, even a couple of months ago, a lot of women who were of that fertile age range planning pregnancy. I will bring up with them that COVID vaccine is something that we do recommend, even when you're thinking about pregnancy. There's a lot of fear about it causing infertility as well. I have seen some quite active disinformation campaigns telling people that the spike gets into their ovaries and all sorts of fun rubbish. So what I tend to do is I will actually book an appointment with these patients to sit down and talk to them about the evidence, about the studies that they've actually done overseas and the vast number of pregnant women that are vaccinated and why we want them to be vaccinated. I had experience in 2009 with the swine flu pandemic. I was working as an ICU registrar at the time, and we had an entire wing of our ICU at John Hunter that was purely pregnant ladies who were ventilated, who had to have emergency C-sections because they were so unwell. And that's sort of what they're seeing a lot overseas with pregnant women as well, is that getting COVID when you're pregnant, you're immunosuppressed, is extremely dangerous. And I think just exploring what the fears are for these ladies and just expressing that, these things have been studied, it has been shown to be safe, and these are the reasons why we want you to be vaccinated. I have had some success convincing a fair few of my pregnant ladies to get vaccinated. Of course, there are a few that are, terrified. So we will talk about other ways to try and mitigate risk and reduce your risk of getting COVID while pregnant. But usually, just the sharing of information, the studies I found to be quite helpful.
Thanks, Amy. I really did see that when we had a vaccine clinic recently up at Cabbage Tree, and I had a yarn to a couple of women, but it was sort of opportunistic. And I had the GP with me, but I wish the Aboriginal maternal infant health team would have been there on the day too. But anyway, if we all keep giving the same messages, that's for sure.
Okay, thank you for that. Now we also have a question from Jade Beeson. Jade, would you like to ask your question?
Hi everyone. I'm currently working as an Aboriginal COVID support officer with patients that are isolating at home, and we've had some patients that have tested negative the whole time while being with other positive patients. If they're still hesitant about vaccinations, how do we go down that road of having that conversation with those patients? And how does that happen?
Patty, I might throw that one to you if you might have some insight for us.
Oh, terrific, thanks. That's a really good question. So the fact that you've been with a positive person, but you've remained negative, doesn't mean that you're not going to get COVID in the future. Yeah, so it doesn't mean that you're protected in some way, and you still need that vaccine. Now, even people, the experience overseas, even the people who get COVID and survive and build up immunity, so they've got their own antibodies, they still benefit from the vaccine. So there's no situation like that where someone wouldn't have the vaccine because they already have some sort of protection against the virus. So the message for those people is quite clear. You've been lucky, still have the vaccine. And maybe they must have really good hand washing techniques or something.
Thank you.
Just throwing back to the question that Virginia asked before, there's also a comment saying that we need to reinforce breastfeeding mums that it is safe to be vaccinated. Would any of our panelists like to comment on that as well?
I often do mention that as well, like with any medication, that, you know, it's perfectly fine to get it done when you're pregnant or when you're breastfeeding at any stage. And I also like to let mums know as well that if you are vaccinated while you're breastfeeding, you know, there is that chance that you can give some of those antibodies to the baby as well. So it's a win-win.
That's for sure, that it's definitely a win-win for both baby and mum. There's a comment coming through that it's unfortunate that trigger to increase vaccination was an outbreak in our area, and a huge congratulations to everyone, including attendees today who have been on track with vaccinating. But we just wanted to make sure that everyone is aware of the great work that we've been doing in our Aboriginal communities, and to say thank you to everyone. Now, this one is where I get started. Were there any more questions? We have about 5 more minutes for any questions that you may have. Okay. So moving on, I would like to take the opportunity to thank Patty, Amy, Therese and Jamie, and each of you for your time today, and everyone who has attended today. You'll be sent a recording of the patient information around long COVID, which was presented by Marsha Files, who couldn't be here today, but she has still recorded the session for us so that we can have access to that. And also a yarning about COVID-19 recorded with Paddy, and he's shared with us regarding a session he recorded with Dane Simpson, a comedian from Wagga Wagga, which the Hunter New England Central Coast PHN has created. If you would like to find any more stats on your own LGA, we'll also be sending you a link that you can find that information on. But on the screen in front of you, we'll be looking for your feedback for evaluation, because it's really important to us. If you could take a few minutes to hover your phone over the QR image and complete a short online evaluation survey. The results of this survey will let us know if you found value in today's meeting, if the meeting format worked, if you would like similar meetings to run in the future, and if so, what topics you'd like to cover and how we can improve things in the future. Now, just saying, we have a couple minutes left, so while you're hovering your phone over that to do the evaluation, we've just got one more question come through. It says, is it safe for children that are anaphylactic?
What we usually do at our clinic with patients with allergies is we assess what they're allergic to, and if they're allergic to any components of the vaccine, we will usually refer them to one of the bigger hubs. But with anaphylaxis to any other substances like peanuts, penicillin, it's perfectly fine to have the vaccine. In fact, the only change we would make is we will probably keep an eye on you for an additional 15 minutes. So you might be hanging out with us for half an hour instead of the 15 minutes, just to be sure. But I've certainly vaccinated my fair share of patients with a history of anaphylaxis without any issues.
And I'm sure it wouldn't be terrible hanging out with you for an extra 15 minutes. I'm certain of that.
Can I just add something? I'm Kathy. I'm the nurse unit manager up at the COVID vaccination clinic in Dubbo. If we have people who are concerned about anaphylaxis, if you contact Jessica Iliff, who is the staff vaccinator at the base, she will actually book an appointment in the ambulatory care centre with Dr. Sean Nugent, and they can be monitored there for the 30 minutes as well.
Fantastic. Thank you for that. Regarding the survey, if you are on your phone and aren't able to scan the QR code, we'll send you the link via the email once we've finished, and then you'll be able to fill out the survey there. So whichever one works easiest for you. That being said, I would really like to take the time again to say thank you to Amy, Patty, Therese and Jamie for your time today. You get a little early mark, so a bit of time to go and spread the word and take it back to your mob and tell everyone what we've learnt here today. And with that, I'll say thank you. See you later.
Thanks, everybody.
Thank you.
See you all.
Thanks,
Have a great
Patty.
afternoon.
Thanks, Amy-Lea.
Wonderful. Thank you.
Bye.
But yeah.
Thank you.
Thank you.
Thank
you.
Bye, Therese.
Thanks. Bye.
Just read. Just say
Hello. Can you hear me, Katie?
Yeah, I can.
Can you hear Therese?
Yep.
Hi, Erica. That went really well. Well done.
Oh, where are you, Michelle?
And well done, Nikki.
Well done. Yeah, that was
There's still a few
fantastic.